There we go. We want to thank SBP, Medical Discovery Institute. You're going to discover some things today from some experts, not nationally known, but some experts in prostate cancer, how much pain it causes. Whether it'll hurt a little, does it really hurt a little or a lot, and so forth. We're going to have 3 of our members talk about their treatment, their experience, their quality of life aspects, things that the doctors don't tell you about. Okay? Here's the group of guys that make this thing run. It takes a lot of talent and effort, and anybody wants to volunteer, we got room for you. And we'll also train you in how to do this stuff. I'm 4 years away from 90, and I'm not going to do this for another 4 years. So anybody want to come up here, let me know, and I can help you on how to do it. And the same is true for Gene. He wants to start to relax. And so if you want to join us, talk to us after the meeting. Everybody get a newcomer package. If you're new here, you should have a package. Anybody missing any? Okay. All right, there's a yellow form on the front of it. Please fill it out. And what's going to happen is Gene will give you a call and welcome you on board and see if you have any questions about our functions and activities. Has everybody got a newcomer package there? Here we go, one. And they're free until we pass the basket. Okay, and fill out the yellow front page and give it to me or Gene up here on the podium after the meeting. Now, what's the purpose of our support group? We share patient-focused experience, particularly today, on becoming your own case manager. You have to manage your own case. Your doctor is not going to do that. He has thousands. And you have to manage your case, and you're going to see a big, fat notebook from John. You got your notebook with you? He brings that into the doctor and slams it on his desk and starts flipping through it because he's prepared questions. And he fills out the forms and so forth. So you should get a copy of all your lab reports and tests and things like that. They belong to you. Ask for it. You want the pictures? They got them. They can send them to you. You may not be able to read them, but at least they're yours. And if you got any questions about them, bring them in the next meeting and we can chat about that. But we're not a substitute for your doctor. We're not trying to replace him. What we're trying to do is maybe give you some questions you may want to ask your doctor. You may hear about something here that was a successful treatment and ask your doctor, would that be appropriate for me? I've had that experience frequently, and the doctor said, yeah, we could do that. But he wasn't going to bring it up unless I asked him for it. Sort of like Lupron. I can't take Lupron. It's a killer for me. And I asked, I heard about Firmagon. Yeah, we could do Firmagon. And it's very gentle for me, Firmagon, compared to Lupron. Things like that we share in the group, and maybe you can ask your doctor about that. I have learned a lot in this meeting. Now, our support to you, we got a website, and guess who does the website? There he is, double-headed. He's a Webster and a speaker. Okay. He's been around forever, which is a good example of what this program can do for you. We got a library out there with Bill Bailey, and we got all kinds of good books. The #1 bestseller right now is here. This one here. Boy, this has got everything in it. Brand new, wonderful book. Schultz is the director of the prostate oncology specialist up there at Marina del Rey. He is an oncologist. We'll cover that in a minute. We got newsletter. Where's our newsletter? Raise your hand over there, newsletter.
No, Steve, raise your hand.
There it is. You find any typos, don't tell them. Tell me, and I won't tell him because he does a wonderful job. And then we have Bill, who does the speaker summary. Here, you miss a meeting, he's going to have a good 1.5-page summary, and then in a month you can get the DVD for $10. And the DVD will have all the charts and graphs and numbers and things like that. So you don't need to take notes if you're interested in the specifics. You can get it on the DVD. And then we have outreach for new members. You folks are our source for new members. We used to run ads, and they weren't very effective because they track these things. It's you people that spread the word and say, come to the meeting. And so we want you to do that, keep that coming in, because the occurrence of prostate cancer is not disappearing. Monthly meetings. Dum-da-dum. An oncologist. Everybody know what an oncologist is? An oncologist is a physician specializing in cancer. Some people think their urologist is a cancer specialist. No, he's a specialist in urinary, bladder, prostate, and liver, and so forth. Those urinary pathways he's responsible for. The average urologist, prostate cancer is only 16% of his business. The average urologist does prostate surgery only 8 times a year. The average urologist does not maintain a good surgical craft because of the infrequent use of that. You got to do at least 250 a year to maintain your proficiency as a surgeon. A urologist is a surgeon. He's equipped with a scalpel and a syringe. Prostate cancer is a little unusual. You find out about it when basically you get a PSA. And your doctor then, your primary care doctor, wants to send you to a urologist because he will do a biopsy. And that's the unusual thing about prostate cancer. The first specialist you see is a surgeon. All other cancers you see an oncologist who looks at different forms of treatment. Well, this guy has already one in mind. He has a scalpel and he has a syringe, so he's going to recommend ADT or surgery. And because those are what he knows well and is very adept at and thinks is probably the best thing for you. So the important thing is to have an oncologist. We have, and you can specialize in oncology, and we have a wonderful oncologist who specializes in prostate cancer. Anybody know his name? Richard Lamb. He comes here in November. He specializes in men's prostate cancer. That's what he does every day, several times. Now we have a new person that we've learned about. I have not met her. You have, haven't you?
Face to face.
Okay, but we've heard a lot of good things about her, so let's get to know her better next month. And she's very well trained in this field on the East Coast, if you don't mind. But now she's moved here, and let's get to know her. I think you'll be impressed. Okay, we're going to survey our group here. We do this traditionally. Okay, please raise your hand. How many are here for the first time? Raise your hand. And look at that. We've got some newcomers here. We're going to have an opportunity to network, and so you get to meet other people after our 3 speakers. How many have been just recently diagnosed in the last few months? Welcome. Okay, and hope you come back, because the more you come back, the more you learn. How many have had prostate cancer for up to 1 year? Okay, now you're going to see, for you people who have had it 1 year, what's it going to look like down the road here? Okay, how many have had up to 4 years? Look at those hands. 5 to 10 years. Look at that. See, you're 1 year. See, we're going to be getting $10 from you for a long time. Okay. 11 to 15 years. Raise your hand. Okay. Anybody higher than 15 years? Okay. I got 21. Anybody beat 21? There's a hand in the back. Jack, how many? 29. 29. When you hit 30, you get a special award. Okay. All right. See, so there's some longevity here, because that's what's happened to the cancer. We got a lot of new technology, and you'll hear about it here. Okay, here we go with some treatment. How many have not had treatment but are in what we call active surveillance? Raise your hand. The more of you are doing that rather than running in and to having it cut out. It used to be a masculine syndrome. Cut the damn thing out, then I don't have to worry about it. Well, cutting it out can cause a lot of side effects, so you want to avoid that. It's essential. Okay, how many have had surgery of all kinds on their prostate? That used to be the gold standard. Now let's see if we can switch it to how many have radiation of all kinds. See, now that's become more the common one now. Okay. ADT, hormone therapy. There's a lot of us on that one. How many are on Lupron? Raise your hand. Okay. How many are on Firmagon? Okay, I'm on Firmagon. Okay, we got a few. The thing about Firmagon, you got to have a shot every month. Okay. But boy, I don't have the reactions that I had with Lupron. Chemotherapy. How many are on chemotherapy? 1, 2, 3? 3. Oh, is that 4? Okay, 4. And new treatments like HIFU, cryo, Provenge. How many are there new treatments there? You've had them all but one.
Zilpigo, Zytiga.
Yeah, so there's a lot of new things coming in. And I'm on the newest one, Erlita. Anybody on Erlita? I'm the first on my block to get it. Okay. Recurrence. How many have had recurrence after their primary treatment? That's why you need to get a PSA after your treatment, because it tends to come back. How many are undecided what treatment they ought to have next? Raise your hand. Okay, you might hear something today and write it down and talk to your doctor about it. Okay, we need your support. We break even on $10. So if you've got a $10 bill, we like bills with zeros on it, by the way. Your donations are tax exempt. We're not affiliated with any medical or religious organization. So we're going to be passing the baskets down, send them back to the group behind you. And while you're digging deep, let me just tell you about our 6 principles. Early detection. Many of you here are because you had an early PSA. Because the only symptoms you get if you have prostate cancer and don't have a PSA is bleeding and pain. And that's not early detection. That may be too late detection. So you want to get a PSA early. You need to have high definition diagnostics. You're going to hear about that today. You need targeted biopsies. You're going to hear that, where they put that needle right through the lesion or tumor rather than the random one. You got to know your Gleason score. Those on active surveillance generally have a Gleason score of, the cell is 3 for a total of 6, and it's pretty safe cancer to have. How many know that there's a big difference between a cell that's a Gleason 3 and a Gleason 4? Okay, your doctor tends not to tell you that. The impression is, and it was mine initially, that a 3 goes into a 4 and a 4 goes into a 5 and so forth. No. A 4 is entirely different than a 3. It has entirely different DNA. It's very aggressive. So if you've got any 4 cells in there, you want to be alert to how that's going. Some doctors think we shouldn't be calling a 3-cell cancerous. It's viewed by some as precancerous, and they don't want to scare them in. But the thing is, the 4 is different, and it's much more aggressive and multiplies faster and so forth. I just want to give you that tip. Chuck and I were up at a conference, Prostate Cancer Research Institute conference, and the expert on that is Dr. Klotz. And he announced, all doctors, everybody knows a 4 is different from a 3. And I went up to him, not in San Diego. We don't make that point clear, so that's why I want to make it clear here. If you've got a 4, you want to be particularly attentive to it. I'm not saying it's going to be worse, but be attentive to it, and particularly when you're doing active surveillance. And now treatment selection is important, but you got to know all these other things before you jump. In the old days, the masculine macho thing was cut the damn thing out. I don't want to have to mess with it. Well, the side effects tend to be more severe than other treatments, so you may not want to jump to that because there are 16 different options you can take, and which one is a puzzle for many of you. Okay, let's move on to today's agenda, and these are not necessarily world-famous experts, just maybe in their neighborhood. We got Tim, Elliot, and John who are going to speak in that order. I'm not going to introduce them because they'll introduce themselves and give you a profile of where they're at now. And then following that, and we're going to have a breakout session, and we're going to have a radiation facilitator down there. Gene's going to be over here after the meeting for ADT, or what's called hormone therapy. Chuck is going to, raise your hand, Chuck. Chuck is going to be back over there, and Bill is going to remove his hands from the camera and talk about active surveillance. He's been on that for quite some time. He's very knowledgeable about it. How many would like to facilitate the radiation? Our normal guy, Denny, can't make it today. Who feels comfortable about talking about radiation? Okay, good, Tim. Tim, you'll be over there. Raise your hand again so people get to see. Oh, you get to see him next, right after I shut up. Okay, let's go back. Okay. Now, Tim has learned a lot, and he's really studied the subject. So let's hear about it, Tim. Come on up.
Thank you.
It's great to be here. It's great to be part of this wonderful support group. IPCSG is the most amazing brain trust. I am so grateful to be part of that, and very happy to be here to tell my story and hope so much that it might help someone else. Is this my clicker, or I can just tap that?
Yeah, this is next slide.
Thank you.
And that's the laser.
Beautiful. Ooh, lasers. Love it. So I'm one of the newer members. I'm 60. No spring chicken, but got a few good years left. I am an electrical engineer. Dead silence. And I went into the dark side of sales and marketing many years ago in the semiconductor field. I now work for a company here, a wonderful company that has been so supportive of me through my ordeal. in giving me time off to see doctors. They're called D&K Engineering in Rancho Bernardo. I'm Canadian born, and have been living here in SoCal. I'm essentially a SoCal person now after 46 years, but moving to Arizona this year, whatever. So my current status is a wonderful status. I am in remission, thank God. After 31 sessions of proton therapy and Lupron. I started Lupron back in last June, and I will continue through the end of this year. PSA currently very low and dropping. My Gleason score last year when I was diagnosed is as follows. So the first one, my time minders have fumbling with my Droid phone. He must be an Apple guy. So I had a kind of an early Gleason score when I was first diagnosed, and then I followed that up with another ultrasound-guided targeted MRI about a month after that. Stage 2 T2B, and never had a symptom. So let's kind of walk through the story. Back in 2016, my PSA was kind of rising ever so slowly. It was in 6 and eventually in the 7s, and that's when my primary care physician suggested I go see a urologist. I was with Sharp-Reese-Steely. I saw Dr. Hergen, Ms. Dr. Hergen, over there, and she prescribed some additional screens, which are shown here, and unfortunately for me, they kind of pointed to not a great picture for me. You know, words like high risk were coming out, and boy, I'm starting to get nervous. She suggested a biopsy. I heard a lot of negative things about biopsies and the risks involved, and I decided I'm gonna get educated. And I actually at Sharp-Reese-Steely, they didn't have targeted biopsy back then. That may have changed, but they were still back in the old ages. She had no knowledge of any kind of support group, which was kind of shocking. So I found out about IPCSG just on a web search and came to a meeting, met the team here, and I've been coming ever since. What a great place to learn about this lovely topic. So, and it was truly the best thing I ever did. IPCSG been very, very good to me. I stayed on the active surveillance road while I learned.
Deep dive, what's deep dive?
Deep dive is when you go full bore in and learn and really take the bull by the horns and read and attend meetings. And so, oops, I think I skipped one. So while I'm going through IPCSG and learning and reading many books, periodicals and so forth, I looked into this naturopathic angle, and you don't hear much about that at IPCSG, but this is basically, these are doctors that work with you on your diet and supplements. And I went to the Lotus Rain Clinic in Claremont, and Dr. Hilowitz immediately prescribed some key lifestyle changes, i.e. a lot more, well, mostly initially the diet came up. We cut out all sugar, all juice. I was a big juice guy, gone. No desserts. I mean, I still have an occasional one, but dairy, no more milk, minimal cheese, animal fat, etc. Already had a pretty healthy diet, but we did cut out some key essentials in my diet, and I started to go to the gym a lot more. I am really pleased about that because I feel so much better now that I'm working out, and I lost 20 pounds. So she also prescribed these, pardon me? These supplements. You may have heard of the, vinegar, organic apple cider vinegar, fish oils and such, lots of vitamin C, etc. Some of you may have heard of the baking soda and molasses and water, cure, things like that. I was trying all this stuff. Looking back, it was a bit of maybe a delay in the real treatment. At one point, she prescribed to, going in and having these IVs, these large bags of 100 grams of vitamin C dissolved into your vein every Saturday. It's like a 3-hour event. I tried that. My PSA did stabilize at about 7.5 for about a year. So it was feeling like it was kind of working. Oh, and she suggested I lower my stress, work less days. My company obliged, and I got it to a 4-day work week, which was awesome. Read a lot about how stress can impact your PSA, your cancer. She also referred me to another naturopath out in Phoenix, Dr. Tamburi, who I went to see. We did a color ultrasound, basically to do a prostate volume check. And he also prescribed some antibiotics to make sure there wasn't an infection in play. It turned out there was no infection. The PSA was real, caused by the cancer. It prescribed more supplements. Oh my God, I was taking 10 different things morning and at night. Drinking a lot of water. So I now drink almost a gallon of water every day, and I actually love drinking water now. No more juice, no more soda. My PSA was pretty flat for about a year until that terrible day in October when it shot up to 9.5, and I'm thinking, it's time for some Western medicine. Let's go ahead and do the biopsy. So thanks to IPCSG, I met Dr. Schwartzberg here. He presented. He's one of the top image-guided, MRI-guided specialists in the land. Met with him and his associate, Dr. Cooper, and we went forth with a MRI-targeted biopsy in January. Only 4 cores. So they were convinced that this was a very focal cancer. We looked at the images together, and we're going to go in right there and take 4 samples. And it was very pleasant. They give you a little bit of an IV drip to calm you down. You don't feel a thing. It was really no big deal to do that first biopsy. Went through, so then the terrible news came out that, oh my, you have a Gleason 9. It's a 4+5, better than a 5+4, but that was a little shocking. The other 3 tissue samples were benign. Working with the guidance from my team, I sought a second opinion and a third opinion. Dr. Hansel, who's spoken here over at UCSD, suggested that the 4.5 could be interpreted as a 4.3. That was very confusing to me. How could a background 5 possibly be a 3, not a 4? But I went with a third opinion from Johns Hopkins University, and they confirmed the first one. So I'm hanging my hat on that 9. As ugly as it is, it dictated, some of my path forward. But what was interesting was, since it appeared at that point that the cancer was very focused in one spot, then I might be a candidate for some of these one-day treatments. Have anybody heard of these focal treatments? It's an outpatient event. You go in for a couple hours, and they trim it off with a laser or cryo, freeze it, or ultrasound. There's different methods. This was looking pretty good to me versus the longer treatments. So the next thing, I'm trying to recall what prompted me. Oh, I wanted to go see Dr. Duke Bond. He's spoken here, very highly recommended doctor up in Ventura. I wanted to get another biopsy with the ultrasound guidance, different imaging technique, which led to a much different outcome. He didn't find the 9, the Gleason 9. He took 12 cores, which was not pleasant, no anesthesia, but no big deal. He's kind of one of those guys, like, take it like a man, no anesthesia for you. Anyway, he comes back. I have now 5 active cores out of the 12, but they're low grade. The problem is I am not a focal candidate anymore because the cancer is actually not in just one spot. So he ruled out the possibility of doing cryo treatment, which he does in his office. So that was a big lesson learned, is that I nearly hung my hat on that one biopsy. 2 biopsies can really make a big difference. It did for me, or maybe a better first biopsy. I followed up with Schwartzberg and mentioned this to him, and said that it might be good to do some additional random samples just to see if there's something else there. And it was a little inconclusive as to what he might do in the future different. So at that point, I am seeking like one of the best experts in the land to kind of help me with all this information. I went to prostate oncology specialists up in Marina Del Rey and visited with Dr. Mark Scholes, the author of this book and other books, world expert, and he set my final course. He recommended radiation and ADT. Cool. I was seeing a Dr. Weinstein at Sharpry-Steele for initial guidance on external beam radiation, the standard radiation treatment. He was not familiar with him. He urged me to seek the doctors at UCSD, Drs. Munt and Eink in UCSD radiation oncology. So my wife was a big part of my research and deciding what to do. We decided I'm going to get out of the Sharpry-Steele network and go into the UCSD med network, and I sought the care of these doctors Munt and Eink, and actually McKay, who's speaking next week. She's my urologist. So Dr. Munt preferred this new proton therapy over the photon therapy, the standard, more common therapy. And so I went up to see Dr. Rossi at California Protons, and they prescribed a 6-week treatment plan along with the ADT, and I decided to move forward with that. Now, one thing, if you do go with proton, there's a spacer that they like to insert. It's a gel. They like to insert that between the prostate and the rectum. Thank you. Which alleviates the need to do another delicate procedure every time you go in, that I won't go into. But the spacer thing is an essential part of that plan, and Dr. Eink performed that. It was his 7th, but it was kind of interesting. There was a room full of people, students and grad students, and the supplier of the spacer product. It was kind of an audience. Dr. McKay in urology prescribed 18 months of Lupron. We started talking about 4 months, and somehow it jumped to 18 months, which we're biting that bullet and going through that. And I'm doing the Lupron shot every 3 months. If anybody is thinking about getting Lupron at UCSD, they will charge you, it's about $1,000 before the insurance kicks in, just for having it done at their Komen Center, which is considered a hospital. So that was a little bit of knowledge that kind of kicked in when I saw the bill. And you can go to a non-hospital UCSD site and see that charge go away. So that was a little bit of learning. So last September, I finished my 6 weeks of proton, and Dr. Eink saw me the day before my last treatment, and he said, you are graduated with honors. You are done tomorrow. Go have a great time in Italy. We're flying to Italy that Friday for 3 weeks, and boy, that was amazing to hear that from his mouth. And I'm like, so when is the biopsy to test this? He's like, no biopsy. You just get the PSA check, which is pretty non-invasive, and just keep an eye on it every 3 months, and then eventually every 6 months after it drops and kind of flattens out. So that's kind of amazing times at that point. I'm standing in front of you now in full remission. I hope to be in remission for a very, very long time. Totally pleased with my outcome. Again, IPCSG was my guiding light. I owe my life to this group here. My wife also as well, unfortunately not here today, but she attended every medical appointment and every decision and everything that I read that was new news. She read it, did her own research, came to all these meetings. Absolutely my rock. I'm so grateful for her, Gretchen. Going forward, just PSA tests, that will diminish in terms of frequency as it levels off, hopefully levels off. Maybe it'll keep dropping forever. Continuing to minimize stress. I am working not full-time, which has been just so awesome for me, maintaining this wonderful diet, mostly vegetables, a little bit of meat here and there, lots of fish, and I'm at the gym 3 days a week. I feel better than I did when I was a single man, to be honest with you. My only regrets was delaying my biopsy. I was kind of going down that naturopathic curve, and I think naturopathic works to an extent. There are some guys that saw their PSAs drop a lot just through diet and exercise. You'll read about these people. But I should have had that biopsy done. Maybe my Gleason would have been an 8 back then, and might have been a candidate for some other less invasive, less time intensive treatment. And I also regret not having more tissue samples at the first biopsy, because having Gleason 6 and 7 elsewhere in my prostate, ruled out my targeted therapy that I was seeking. I spent a lot of time researching targeted focal therapy. And that's my story. How are we doing on time?
We're going to hold the questions till all 3 are done, and then we'll have a check on that. Okay, thank you.
Mm-hmm.
Let me just point out something for you guys, that when he saw A.J. Munt, who was our speaker last month. Here's A.J. Munt. He's got all kinds of radiation equipment there, but for this guy, he recommended proton. He had to go to see a different doctor with different instruments and things like that. That shows you how good he is. He's thinking of the patient rather than trying to keep the patient. He sent him to see Dr. Rossi, and you benefited from that. Incidentally, I know that Munt was here when Dr. Rossi talked about new advances in proton, and mentioned spacer for the first time. I happen to know the person who had the first spacer test done. And A.J. Munt was here and heard that and looked into it. And now see, he's picking things up. He comes to these meetings and picks up some hints and things like that. So we've got some good speakers there that also listen in addition to talk. Okay, now the next speaker, I asked to volunteer. Last month when we did our survey of new treatments, I asked the group what kind, and this gentleman said HIFU. How many of you have heard of HIFU? Okay. 8 years ago, we had Dr. Chang, was it? Yeah, see, the memory's still up there. Dr. Chang talked about HIFU. It's very experimental, and you can't get it readily around here. So we got the leading expert as a patient about HIFU in San Diego. Elliot, come on up.
Good morning. Good morning. As George mentioned, I indicated I had HIFU at our last meeting, and he asked if I would share my experience with the group, and I said, sure. Why not? We had a good experience, and I'd like to share it. So, as the last speaker mentioned, this was a joint effort. It's our journey. It wasn't just mine. And so my name's Elliot Chev, and this is my wife, Dr. Wendy Mauer. Hi. And I'm 71 years old. I live here in San Diego, and I'm a general manager of an electronics manufacturing company in Tijuana. Which one? Sumatronics. I'm an computer engineer who went into sales more,
We need to stick together.
Yeah.
Yeah.
That's what I was
Became a
thinking.
black hat.
Yeah.
All right, and now I have 600 employees down in Tijuana.
I'd like to just let you know that I'm a clinical psychologist. I specialize in grief and loss, and I wrote this book many years ago to take to the doctor's office. It's a workbook to help you fill out what you need and carry what you need to the doctor's office so that you can be your own case manager. It cost me $20 each to make, but I'm going to be out here. If you can't afford it, I'll give it to you. If you can afford it, please pay me, and I'll give some of it to the great group here, some of the money too. Also, I have a card. I'm not trying to solicit work, but I have this great card about normal reactions to trauma. Those of you who are just new at this and long-term, you know how it's affecting your body, or if you don't know, it's right here, and things to do. So any partners here that don't have it? It's just me today. All right, well, go give them lots of hugs and kisses when you go home.
Here's the timer. Okay, current status is my PSA is 1.7. I feel great, and all my bodily functions are working just perfectly.
I'll vouch for that.
So the background is every year when I get my annual physical, I get my PSA checked. My PSA was normally around 3 plus or minus 5, depending on the year I looked at it. When I went back and put them all together, it was 2.3, 2.8, 3, 3.2. So it was all in the generic safe area. December 2017, I had my annual physical, and the PSA came back at 4.7, which immediately raised questions. What happened? My internist said, hey, first thing we do is antibiotics for 2 weeks. Let's make sure you don't have an infection, and we go on a wild goose chase here. So we did that. 2 weeks later, I took another blood test, had a PSA check. Didn't go down, went to 5.5. So we said, hey, something's going on. He said, we can do watchful waiting, or we can, and I said, what's that? And he explained it. I said, or you can go to a urologist and we can inspect this further. Being a type A that I am, I wanted to get involved right away. I wanted to know what I was dealing with. So we chose to go to a urologist to take some immediate action. So the urologist did as been explained what they do. He said, oh, we have to, first he let me know how long his finger was, as we all have experienced too many times.
And he promised me no one else would touch him.
Yeah, every doctor I went to during this process did an examination. And he said, we need to do a biopsy. Well, we're babes in the woods here. We don't really know anything. Okay, let's do a biopsy and find out what's going on. So the biopsy has a funny part and the sad part. Well, the funny part was I get all ready to do the biopsy, do the prep, go in the office, get the antibiotic injection, get undressed, get on the table.
In position.
In position, the nurse walks in and said, oh, I'm sorry, but we're gonna have to postpone your biopsy. I said, you are kidding, right? She said, no, the doctor got called to the hospital. So got dressed and went home and repeated the following week, the same thing. Anyway, I had the biopsy, and I don't think it was a pleasant experience at all. I thought it was a pain in the ass. And we waited for the results. So we went back 2 weeks later.
A couple of weeks later, yeah.
Yeah, to get the results, which were Gleason score of 4 plus 3 equals 7. Later, the radiologist we went to see told me it was stage T2B. So the urologist ordered the staging process. I had a high contrast MRI of my abdomen and a full bone scan of my body to see if it had spread anywhere else. Fortunately, it was contained in my prostate. There was nothing else was found. So we met with the radiologist and
Well, so I think doctors are certainly wonderful, and they're trained to be experts and talk like they're experts, so that we feel confident, and they know only what they know. So that's why this group is wonderful, and that's why we needed to also learn more. But he was adamant that because of the numbers he saw, the information he had with Elliot, that there were only two choices, no matter what. And those choices were surgery or,
Radiation.
or radiation. So that's one thing. Oops, sorry. Yeah, so he also told us that that Elliot was done with sex because he was 70, and he wasn't, and even if he were 69 and a half, it would be okay, but now that he's 70, never again will he be able to have sex.
black and white, that's his opinion.
Well,
Anyway,
his research from talking to people.
yeah, so he says, all the patients don't talk to the radiologists and the surgeons, they all come to me with the problems, and this is the results. I said, well, what else can we do besides radiation and surgery? He says, there is nothing else. I said, well, what about brachytherapy? I've heard of that. He said, nobody does it anymore, that's passé. So I said, but they do it right here at UCSD. So I changed urologist.
Well, he was a good man. He's a good man, but
He's really nice.
anyway,
Many
so-
of you may know him, but no names provided here. He gave us recommendations to see a surgeon and a radiologist. Both, I think, are really good in what they do and experts. They were
Yeah.
very satisfied with our consultations.
so we,
One thing we did at our consultations, one thing I want to say, all the doctors we saw gave us all the time we wanted. Nobody rushed us. They answered every question we had and made us feel real comfortable. The other thing we did was record every conversation we had. We had conversations with all these doctors and other people, and every conversation we recorded and transcribed, because what we found out is 10 minutes later, we didn't really remember what they said.
we would argue on the way out of the meeting with what we just heard, and we're both not so dumb. So the research shows that when you're stressed, your memory doesn't work as well, your ability to ask questions doesn't work as well, so no matter how type A or how smart you are and everything else, don't expect yourself to be 100%. So that's why it needs to be recorded. And also, after you record it, transcribe it. There are lots of companies out there that will do that for you in a few minutes, and then put it away.
Did you inform the doctors that you were recording?
Yes.
Always ask.
After we asked their permission, and we had placed the recorder right between us. So
And-
yeah, there's full disclosure.
Right. And every doctor we went to, whatever treatment it was, we were convinced on our way out, yeah, that sounds really good.
Let's sign up.
Yeah, so,
Anyway, so why we're here, how did we arrive at HIFU? So we needed to collect a lot of information. We talked to family members, talked to every single person we knew. And fortunately, we have some family members who are fairly well versed to talk to. Wendy's niece is an oncology radiologist who specializes in prostate cancer at Johns Hopkins. So we had some good, free, non-parochial advice. In other words, she wasn't selling us anything. Other friends are involved in radiation oncology that we have in the family and family friends. So we talked to lots of people. And then the other thing that Wendy did is every time we were around a group of people,
I
if
would
there
count.
were men there,
oh, there are 3 men here, I have to find out.
what's your PSA? Hey, we're out for a cocktail.
He would go hide for a second and come back. Yeah.
What we learned is, to my surprise, is that we don't talk about this stuff. It's a big secret. All these people, oh yeah, I had prostate cancer 10 years ago. I had this and this. Everybody had a story.
Yeah.
It was just something we don't talk about, which we found out through keeping notes and talking to people. 2 of our friends had HIFU and had excellent results. And so we started to look into that.
Right.
Because what they told us sounded very exciting.
Now, I just want to say, we wouldn't have known if I hadn't written down a little paragraph of everybody we talked to and what they said, and then put it away, because we didn't even remember that one of my friends had HIFU. But when I looked back, then I realized that, and so we called him again. So please, just record everything.
Yeah, so after these impromptu conversations in parties and whatnot, Wendy wrote these notes. And the one person she forgot about happens to be a doctor.
Yeah, my good friend who's a doctor did the HIFU.
Yeah, so he did it 10 years ago.
Yeah.
It was quite a while ago. So when we learned about HIFU from these conversations, we said, hey, let's look into this, because we don't know about it. So obviously we went to the internet first and started looking for things. Basically, if you don't know the definition of HIFU, I got it right there. And not everybody's a candidate for HIFU. So one of the things that seemed to be important, this is from this Stanford Healthcare document I found, but basically your prostate has to be of a certain size. It can't be swollen and inflamed, and the cancer needs to be in the capsule and localized. So there's some conditions that apply to if you're a good candidate or not.
Talk about the MRI.
Yeah, and one of the things that we learned by doing research before I contacted doctors was they needed a HD or a high definition or a 3D MRI in order to determine if you're a candidate or not, which we didn't have.
So this is really important, because the state of the art now that we're talking to other people is that you don't do the biopsy first. You do the 3D MRI, and then you do the biopsy, and I guess that's one of the things you learned. And so if you haven't done this part yet, make sure you do this in the right order for yourself.
Yeah. So here are some of the places we contacted and collected information from. This is the doctor that I just chose to go to after our research. This was done in Sarasota, Florida. I was there for like a few hours, so we'll get there. One of the things that Wendy talked about is keep this data and keep it in one place. We have a small cardboard box. It's a little bit bigger than a regular binder, but all the transcriptions, all our books, all the research, all the doctor's notes, every single thing we did during this 6 months of research is in this box. We want to know, oh, this book's here too.
Actually, it was a bigger box at first.
Well, we didn't fill it up, so we consolidated to a smaller box. But in this book, it's great stuff. It doesn't talk much about HIFU. There's just one comment about it. So that's research isn't in there, but there's plenty out there. And if anybody wants, I have a lot of data that I can email you, a bunch of PDFs and links and stuff. If you give me your email address, I'd be happy just to send it to you.
Yeah, this box is important. Since I'm a psychologist and this is what I do, I just want to take a moment. You don't want this stuff all over the place. Well, I walk in the door and I'm going to put it down here or here, because you want to make sure psychologically that you look at it when you want to look at it only, and that it's not here to remind you at other times. So keep it all in one place. Go to it when you want to. By the way, the box was bigger. Elliot didn't know that because I put everything in that box, and then as I didn't need some things, I would take it out. But, you know, cancer will bombard you anyway when you least expect it. You don't need to do that yourself, so please keep it contained.
All right, treatment and results. Remember, 3D MRI, HD MRI required. Don't forget that. In my case, my cancer was localized into one side of was T2, one side of my prostate, and consulting with the doctor, I could have ablated my whole prostate or just half. I chose to do half for a number of reasons.
My choice might have been the whole thing.
We're still discussing it. So it's an ongoing conversation. The treatment was about 2.5 hours. I was entirely sedated, 100% out.
You can't even fart. You can't move at all.
Yeah, you
No
have to
moving.
be total anesthesia. I was there for about 4 hours. My 90-day PSA in the first week of December last year was 1.7, down from 5.5. Obviously, it'll never be 0, so I still have half of my prostate, right?
So half is watch and wait. Right.
So I'll go every 90 days for the first year. So I have another, the first week of March, I'll get another PSA done. And I already have scheduled 1 year MRI and checkup with Dr. Ciante to go back there. And that's about it. So as we always say, be your own advocate and be your own case manager. Nobody cares more about you than you do. So you got to take care of yourself. And we learned that the nicest doctors we spoke to, you know, what they did is what they wanted you to do. And you just have to get all the data and decide what's best for you. And we're all different. You know, we're all going to come up with a different conclusion. As we mentioned before, get the MRI before your biopsy. Talk to everyone you know. Don't turn away any loving support from friends and family. They may tell you the one thing that guided you to the path that you chose. As we mentioned before, doctors mean well, but they may not give you your best solution. And, oh, did I mention? Be your own case manager.
Elliot will be here when, at the end of the meeting too, in case you want to talk to us after the breakout, specifically about HIFU. Okay, next, Jim, come forward. Now here's his big notebook, and he's going to read every page in it for you.
It's double-sided.
And John, I've known since I first joined this group, and he was at one point a young man, and a young man who had prostate cancer. So I didn't say he's old now, but he's done very well, and he's a prime example of what chemo can do for you.
Hello, everyone. My name is John Tassi. I am 63 years young, as George would say. I work full-time, engineering manager for satellite communication, so I get to deal with the birds in the sky. I'm in remission and have been for 9.5 years. A lot of people, a lot of doctors we've had are here to talk about people that have prostate cancer and what to do about it. Well, what do you do if it doesn't return? Yeah. So that's what I'm going to go through. First, I'm going to give you a brief history. First, just a real quick disclaimer. Can everyone read this okay?
I got it.
It essentially consult your doctor. Don't take what I'm saying today as gospel. This is me, my experience. Everyone will have your own experience. Hopefully pleasant. So let's go just real briefly through the history of how I got from where I was to where I am today. So at age 44, the very first PSA I got, at age 44, I had a PSA of 1.1 and a normal DRE. That's really important. Follow that through this. 47, PSA was rising a little bit, 2.4. At age 49, it was 3.5. At that point, I had prostate cancer. The doctors missed it. At age 50, they diagnosed me with BPH. No, I had prostate cancer. Incorrect. So they prescribed medication to shrink my prostate. The problems I was having went away. The cancer kept growing. At age 52, I had another PSA test. It was 19, but my DRE was normal. That is the reason at age 50, doctor said, and I'll remember this for the rest of my life, oh, you're too young for prostate cancer. You don't have prostate cancer. So that started my journey. In December 2007, I had a biopsy, and I had a 3+3 and a 3+4, so I had a 6 and a 7, which is what it came out with. I had, then at that point, surgery in February 2008, and post-surgery, after they removed the prostate, I had a 4+5 on both sides, 25% involvement. So I had a prostate cancer of 9, a Gleason score of 9 on both sides. That's fairly aggressive. Yeah, so 8 months later, I was doing great for 8 months, just enjoying life. But 8 months later, PSA started doubling. So at that point, I went and had IMRT, 37 courses. I had 5 courses of chemo. And then I was 12 months on ADT, which is Trelstar. My PSA from that point on has been undetectable. So that's 9+ years. So that's a brief history. Now, why did I choose the treatment? Who helped me? That's kind of important. So after the biopsy, the steps were urologist, not a prostate cancer specialist, he's a urologist. I've heard that they have a total education of about 40 hours for prostates in the entire curriculum for urology. So I was a sheeple. I just blindly went along with what he said. Oh, you need to cut it out. So he recommended a surgeon. I went and saw this surgeon, and how convenient. There was an opening 2 weeks later. So had the prostate removed. Was feeling great. And then again, 8 months later, PSA showed that it was doubling every 2.5 months. It was the doubling time. The doubling time for prostate cancer is a precursor to how aggressive it is. If it doubles in 12 months or less, they consider that fairly aggressive. 2.5 months, that's pretty aggressive. So at that point, we looked back and said, today, what they'll do is if you have an aggressive prostate cancer, they will do multiple treatments. They'll do the surgery, they'll do radiation, and then they'll follow that up with whatever. That's now what the standard course is. Back then, 2009, that wasn't. So at that point, I decided I need to become my own case manager and try to figure this stuff out, because obviously the doctors don't know what they're doing, or at least the ones I chose. That's when I found this group, and like many people will say, this group, Gene, Lyle, George, well, maybe. Most of them saved my life. I would not be here today if it wasn't for those gentlemen. And I thank them. Well, sometimes I thank them. The other thing I decided to do is go to a prostate cancer specialist. Urologists, surgeons, they're not prostate cancer specialists, they're specialists in their little field. So I decided to go and find one, recommended by this group, and many of us go to see this particular person up in Marina del Rey, one of the best. And together, and I can't emphasize enough, we, the doctor and I, mapped out my best course. Not something that benefited the doctor or the organization he belongs to, but my best interest. We went through a bunch of charts looking at different variables. And the best course of action, because of how aggressive it was and the fact that I had positive margins and I had a 4+5, I had a 9 on both sides, we came up with radiation treatment, followed by chemo, and then followed by ADT. He said, if you do that combination, you have about an 80% chance of remission. That's still, I looked back then, well, that's still 20% of maybe not. You got to switch it around. So what I did at that point, knowing my course of action, I researched the best doctors. The key to this is if you have a transmission problem in your car, do you go see a radiator guy? No. You go see a specialist. And that's exactly what I did. I seeked out the best radiation doctor, the best chemotherapy doctor, and ADT is not a big thing. That's just a shot in the butt every 3 months. So that wasn't hard to figure out. How do you find the best doctor? The way I found is you ask that doctor, if you had the same problems I have today, who would you go see? You take that name and you research that name, you go have a second opinion with that doctor, and then do the same thing over and over again. So I do 3 opinions for radiation, chemo, and ADT. And because of what we came up with, the plan, chemo, radiation, ADT, I'm here today. I would not be here talking to you had I not gone through all 3. Which one of those actually cured the cancer? Who knows? If there were 3 of me with the same problem, we could have done a really great study. But unfortunately, it doesn't work that way. The best takeaway I can give you from what I have learned is you have to be your own case manager. That doctor, you walk into the room, they're going to read your case, try to remember you from the other 2,000 or 3,000 patients they have, and come in and give you advice. Here's what I do. This is what I bring in. This is every medical record, every question, every lab result that I've had. And I will go into that doctor with questions written out. And in fact, if you Google me, I did a news interview with Dr. Shimizu, who was my radiation doctor. And they talk about the process of where I would come in and ask him questions. And he would have to go off and research it because he didn't know the answer. And I can't emphasize this enough. Do not be afraid to fire your doctor. I have fired 3. Thanked them and excused them. I got up and walked out of the room. Total shock on their face. And they had the gall to still charge me. Request every medical record you get. It's getting easier nowadays because everything has to be electronic and everything's pretty much online. I still take a paper copy and put it there. Reason being, if I decide to move out of state, which Arizona's coming up in 91 weeks, but I'm not counting. All medical records, and also very important, a condensed copy a condensed version of everything that has happened to you. And on that is extremely important. I have a copy of this in my backpack, a copy at work, a copy everywhere, so that if something were to ever happen to me, everything the doctor needs to know is right here. Medications I'm on, any supplements, OTCs, allergies, who to call for emergencies, all of the procedures I've had done, and the dates, and the doctor, and the location. And also on that, this is one of the fun effects of chemo, is called neuropathy. I have no feeling in my fingers, so I stumble a lot. This is a list of all my doctors. Addresses, phone numbers, my pharmacy, anything important like that. And then one of the more important things, if you take a supplement and it has certain ingredients in it, you should have a list of what those ingredients are on that. So that if you're in an emergency and they need to do something to you and they need to find out, have you ever had a certain kind of mushroom? I used to take some mushroom supplements, and some of those have side effects on certain medications they will give you in an emergency situation. So it's kind of important to do that. How am I doing on time, George?
You're running out of it.
Okay. I'm almost done. I only have 6 more pages. So what I just showed you is going to be in the slide, so it'll give you a little overview of how I organize my carry sheet. It's basically the important pages of these 3. Third one being, the other important one is any DC'd, discontinued medications. If you're on a medication and you go off of it, it should go on this chart. Reason being is that gives the doctors your medical history of what you've been on that may not have worked or gave you a side effect. So those are just a few of the medications I've been on. And that's all I have. Thank you.
You can see the discipline that he has, and that comes from the space program. You know, you really have to have a very good handle on things. Don't believe everything you hear, and check and follow up. Okay, let's take a few minutes if you've got questions before we go to breakout. And I'm going to start down here, and we're going to do a sweep, and we'll do it in 6 minutes. Question here? Okay, you got a question?
This is my second meeting here, and my mind is changing, and thank you all. But my biggest question is, what is it about prostate cancer that, I'm saying this wrong, that you can't trust your doctors? That you know, why, when you suggest something, they say, oh, blah, 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 and then you have to find out the real way to do it here. I don't get it. I feel trapped right now, and I can't break out of this, my doctors, you know.
Okay, as I mentioned, an oncologist is an important person to give you a spectrum of treatments that you need. Most people don't go to oncologists. By the way, Tim, you labeled her as a urologist. She's an oncologist, okay?
Is it money because is it the
No, it's just, we're into specialization. And I went to 5 different doctors for my first treatment to figure out which one. I went to 5, and everyone said theirs was best. And then I went and I had the same radiologist that over here, and I asked him a question: if I were your father, what would you have done? Wow, that kind of personalized it. My dad, and he.
The truth?
Yes, right? It's very hard because, see, urologist is a wide spectrum of things. So if you go to a specialist, now you're going to get the specialty. And as I mentioned, there's 16 different kinds of treatment compared to most other diseases. There's such a spectrum. Heat it, freeze it, laser it, cut it, so forth. Okay, question here? Okay, back there?
I just wanted to add that things are changing so quickly that everybody can't be an expert in all of them. So that's why you have to also explore and come back to the doctors with what about this?
Yes, the urologist does not read the radiologist journal. Okay. Questions? Any questions? All right.
I had first biopsy, my lesion score is 3.4, and I put on, and they put on thin rye and Bowman. I had side effects from both of them. By taking the thin rye, I dropped that, my PSA dropped down to 5. I stopped taking them for 6 months, now it's 7. My problem now is, what do I do now?
I'm not a doctor, and I'm not going to tell you. Have you had a? Who's your doctor now? What is his specialty?
It's urologist. I go into this meeting, I tell you what, I've learned more than any place else, and this place is fantastic.
Okay, talk to our next speaker next month. Give her that question, all right?
All right, thank you.
Okay, Larry.
Elliot mentioned that he had a 3D MRI. Could you explain a little bit more about what that is? Because I haven't encountered it before. It must be something new.
It's fairly new, it's just newer technology. It's the HD MRI, where they get a high contrast colored picture of your prostate. So and the way the Sonoblade HIFU system works is that MRI data is loaded into the HIFU machine, so they know exactly what they're looking at and where to target the ablation, so they can see it.
So you don't get this just anywhere. It has to be a surgeon.
What's the guy's? No, there's a number of places to do it, but imaging healthcare. That's where I had it done. They're over here on Tennessee.
Okay, any questions here? I'll tell you what, let's do our breakout session.